So today's class is on medical emergencies. There you are. So within emergencies, a radiographer's role, even though we're not permitted to necessarily give assessments on patients, we still have a huge responsibility because number one, patients are coming to us with possibly a problem. It could be an inpatient or something like that of a different scenario. So we have to be able to assess our patient condition visually based on how they were when they come to us and how they are when they're leaving. Part of the assessment is us being able to identify anything outside of the norm. So if we do notice something outside of the norm, you can either call a code blue, obviously if your patient's not breathing, or if you have a situation where you just notice your patient condition is declining, they're still breathing, but something has changed. There are different ways you can call, like I know where I work, they call a METS team, you can call a support team. It's not the actual code team that comes, but there's different teams that can help to assess and stabilize a patient because we're not the ones permitted to either administer medication or make that assessment ourselves. So when we're assessing a patient, you want to assess once they come to you, and if they're talking and everything's fine, and then all of a sudden after you take the test and they're out in the hallway and they're not responsive or something's going on, we should be able to determine what level of unresponsiveness a patient is at. So the scale that's measured for neurological assessment is called the Glasgow Coma Scale, and it's on a scale of 0 to 15, 15 being the most responsiveness a patient can get, and, or do I have that backwards? Yes, that is correct. 15 being the highest function, and 0 being zero neurological function at all. We as radiographers don't have to know that actual Glasgow Coma Scale, but there are certain things within there that we can inform or pass the message on to when we're giving a report or some sort of assessment. Yes, the patient was fine, but then when I went and spoke with them, some people do like the finger on the eyeball test to see if there's some sort of reflex or reaction. That's part of a neurological assessment as well. You want to check for labored breathing. You may be doing a chest x-ray 2-view series on a patient and you know that they're having breathing problems, but then after you have them hold their breath, they may be struggling, and labored breathing can tie into what we did with our vital signs when you watch respirations. If you notice that a patient was breathing steady and stable when they first came to you, and then you see an alteration in their breathing patterns, whether it be deep inspiration or just very shallow breathing or intermittent breaths at a time, that's something that you need to be aware of and pay attention to. And of course, there's the patient that just becomes unresponsive. They may be in cardiac arrest or respiratory arrest, and they don't have a pulse. They no longer have a pulse. Very rarely does this happen in the radiography department, but it does happen. When it does happen, we're the ones that need to respond quickly. Obviously, if there's assistance, you aid to the patient first and then let the other person know to call for help or call the code button. Or if you're by yourself, you would definitely proceed to seek emergency assistance first, like push the code button, call someone, and then go aid to the patient. We're all trained in CPR, so we all know the basic assessment that we need to do for patients. You have to try to arouse them, see if they're okay, check for a pulse, see if they're breathing. If they're not breathing, that's when we take the next step and contact someone. So with the shock continuum, part of emergency room patients are on a shock basis. We don't necessarily deal with patients that are in shock. We do see patients that have certain specific shock types, but we don't necessarily treat a patient that is in shock. Usually that's when they come into the emergency room, they've done all the blood work, done the assessments there, and they may ask for like a chest x-ray for follow-up because the patient may have to go to ICU. So more than likely, if you have a patient that's in shock, it may be a portable chest that you perform. With the onset of shock, you have cellular changes that occur. And that is the body's mechanism trying to help recover the body or restore the body. So you have things like the organs may shut down, or you may see patients start to turn cyanotic. You may see them hyperventilate when they're breathing. They may start to turn cyanotic. And that's the progression of the actual shock condition. So blood is shunted away from the lungs, skin, kidneys, and GI tract to accommodate the heart and brain's need for oxygen. There are 2 phases within the shock continuum, and that's compensatory and the progressive stage. The compensatory state may be when you see a patient, they may have IV contrast, and then they're having some sort of a reaction to it. So they may get cold and clammy. They may also start to experience nausea and diarrhea. Sometimes the diarrhea is it's a function that the patient cannot control, and that's just a reaction from the body's cellular changes, and the body may be trying to excrete excrement, if you would, to try to compensate to take care of the other physical conditions within the patient at that time. You'll start to notice a patient's anxiety may increase. They may start to hyperventilate. They might start to freak out. They may turn red. They may become very hyper. And all this at the same time, their blood pressure may be decreasing. Usually at this stage or at this point in time, if their anxiety is increasing, that's because they may be struggling to breathe. And if their blood pressure goes down, this is where a patient can actually code. For your progressive stage, this is the peripheral circulation reacts to chemical mediators, and fluid leaks from the capillaries when the organ systems will begin to fail and shut down because all the blood is being rushed away from the organs to help the lungs and the heart and the brain. Within emergency situations, there are different types of shock. You have hypovolemic shock, and this may be one of those situations where you see a patient maybe losing blood externally or internally. This patient may have a GI bleed, so they can be losing blood internally somewhere. They may have just had a procedure done, and the artery may be nicked and they're bleeding internally. The other external factor of hypovolemic shock would be, let's say, for example, there was a patient that has severe trauma and injury, and they're bleeding out. This is where you'll start to see the signs for hypovolemic shock. For this type of patient, the blood pressure will start to decrease, the heart rate will go down, and the respirations will change. Bless you. The third type of shock is distributive, and the three types that fall under that category are neurogenic, septic, and anaphylactic. Neurogenic shock results from the loss of sympathetic tone, causing vasodilation of peripheral vessels. This usually occurs with like a spinal injury, severe pain, neurological damage, or the depressant action of any medication. For septic shock, that's, someone give me an example of where you think septic shock may derive or originate from.
Like when you have a really bad blood infection and some of your body functions start to decrease?
Correct. So what we talked about a couple different types of infections where that might be possible. Where do you think that might happen? So like if a patient has a catheter, a triple lumen catheter, and it's infected, it gets into their bloodstream. That's a considered septic shock, an infection in the blood. Also, a urinary tract infection can turn into sepsis. If it's not treated appropriately, this is where you may see some patients that, you may see this more in elderly patients that may have a catheter and can't speak for themselves, so they're not able to inform someone of any discomfort. So by the time they get to you, they may be presenting with dementia-like symptoms. Even though they don't have dementia, they may become agitated, and those may be symptoms and signs of a septic patient from a urinary tract infection. Anaphylactic, where would you see that? And radiography, from what? From contrast, correct. Anaphylaxis does not just occur in imaging. It can occur with anyone who has an allergy to anything. So people who are allergic to bee stings, their reaction if they're not treated with epinephrine right away, that's very similar to the anaphylactic shock that a patient would experience after having IV contrast. The throat will swell up, the lungs may fill up with fluid, the lungs may actually close up as well. The patient might start to swell and turn blue and lose oxygen. Even though diabetes mellitus is considered a disease, it can also be considered an emergency if it's not catered to or treated properly. So the most common issues with diabetes, or let me define it first, actually, so you understand. It's a metabolic disease resulting from chronic disorder of carbohydrate metabolism. As we all know, sugars turn into carbohydrates within the body, and the pancreas usually secretes insulin. So if your patient is suffering from hypoglycemia, that means that your patient has a lack of insulin and their blood sugar may be low. So if you see a patient that may have hypoglycemia, sometimes they'll give you this like blank stare when their sugar goes low, like they understand what's going on, but they can't respond to you, so they'll kind of just give you this blank stare and they'll just look at you. You'll start to see them sweat a little bit. They may turn cyanotic. So first thing you want to do is make sure that you sit the patient down. And obviously within the medical history, you probably know if they were diabetic or not. So you contact the nurse, and more than likely they'll probably give them some orange juice and cookies just to get that sugar up a little bit. When do you think you might see, us as radiographers, you might see the situation of hypoglycemia?
Someone's been fasting or something.
Very good. Patients that fast, diabetic patients that fast in the morning, you may be likely to see this. So a lot of, if you're scheduled in fluoro, if you have to have patients doing a procedure, they've been NPO, they can take medication and they may be able to take their insulin or their medications, however their sliding scale works, but you have to bear in mind that they haven't had anything to eat. So that's a very important question to ask your patients, especially if you're performing a procedure on them first thing in the morning. Are you diabetic? Have you been fasting? So that way you have this insight to, if I see my patient starting to decline, you will probably know what is going on. DKA is diabetic ketoacidosis. This is found in type 1 diabetes, not type 2. It's the most common, oh crap, nope, that's not what I wanted. Here it is. It occurs when insufficient insulin causes the liver to produce more sugar, resulting in hyperglycemia. So these may be the patients you see in the emergency room when they come in and their blood sugar is at the levels of like 300 and 500. That's considered diabetic ketoacidosis protocol, and they need to be hydrated in order to get the sugars down. They may also, you may see these patients also have a Foley, because when you have increased enzymes within the liver and the kidneys, the first thing you should do is flush them out. So they probably will put a Foley in a patient that has DKA and give them a whole bunch of fluid so they can try to rush out those bad ketones through their system. Has anyone, what does syncope mean? Just in layman's terms, what do you think? Fainting or passing out. You may also see this in patients that are fasting as well, because they haven't had anything to eat. So it's basically a transient loss of consciousness. If your patient suffers from syncope or has a syncopal episode, they may, this can be anywhere from patients seeing a needle to seeing blood to actually, that's what they came in for, is they keep continuously passing out, and you may see the patient pass out on you. If you do see a patient pass out, you still have to report it, even if they don't fall, because it's considered a near miss. And basically what you would do is after you've assessed the patient, you've helped them, just help them down to sit down or help them to the floor, to the ground, to get closer to a level plane to make sure that they don't either follow through with that with a seizure or continue to pass out. And we all know stroke. What does the F stand for? A.
Arms.
S.
Speech.
T. Okay. If you notice the patient's having a stroke, what do you do? What was that? No, not necessarily, because that doesn't mean the patient is having respiratory distress. But if you, so you want to call 911, obviously fast. If you're in the hospital, you want to call whatever rapid response team that can come as quickly as possible, because what's the time limit for the golden time? Yes, it's an hour. So from the time that the stroke was noticed up until 1 hour is when the patient can be treated with TPA in order to remove the clot. Hopefully it's not a brain bleed. That's usually the two ways of stroke. It could be a ruptured blood vessel within the head, or it could be a blood clot within like the carotid arteries or somewhere within the brain. For a cardiac arrest, it's essentially when the heart ceases to beat effectively, respiratory arrest is some sort of airway obstruction. That doesn't mean it's a foreign body obstruction. It's just an obstruction of the airways within itself. You may see this in patients who have consistent respiratory problems. You may see this in patients who have metastatic lung cancer, pulmonary embolus. Even though I already have that on here as a separate, that's considered an airway obstruction because it blocks the blood to the pulmonary branches. And if blood can't get there, then it decreases the oxygen supply. A pulmonary embolus is the same as what if it's in the legs? Yes, but what is it called when it's in the legs?
DVT.
DVT. So a blood clot is a blood clot is a blood clot. It depends on where it is within the body is why it's called different. So a blood clot in the legs or lower extremities is considered a DVT. And that's a deep vein thrombosis. And a PE is a pulmonary embolus, and that's basically when a clot has traveled up from somewhere. When can someone usually obtain a PE? After surgery, yes. That's why it's very important. Almost after every surgery, even hip replacements and knee replacements, they have you up, if not that same day, the next day to help keep your blood circulating to reduce the risk of blood clots. Sometimes they may post-op, depending on how severe it is, they may put you on blood thinners after your surgery just to prevent you. Like if you've had open heart surgery, obviously day one, you're not going to be up and walking. But they do provide medication for that. And this is something that we need to look out for as radiographers as well. If we know that a patient is post-op and they're having trouble breathing, it could be a number of different things. They may have acquired pneumonia from the ET tube that was placed, or they may have gotten a clot that was thrown off and developed in their leg, traveled up to their lungs, and it may be a pulmonary embolus. Patients can also suffer from seizures. A seizure is an unsystematic discharge of neurons in the cerebrum that results in an abrupt alteration in brain function. Has anyone witnessed a seizure? What kind was it?
I witnessed a mini one.
A major one?
A mini one.
Mini one?
Yeah, guy started freaking out, and then he like came back to the room.
Yeah, and he didn't know what was going on?
Yeah, he was out of it.
Yeah. What kind did you see?
Just like a little mini one too.
Okay, how about you?
A major one.
Okay, so the whole body shaking, seizures, biting the tongue, okay. So you have two different types of seizures. There's generalized and then there's partial. Generalized are usually the major ones. Those are ones that you may see with epileptic patients that may be triggered from light sensitivity or the sense of a smell. A smell can trigger a seizure. So this generalized seizure, like I said, that may be considered the term grand mal. I don't think they use those terms too much anymore. So there's grand mal and grand petit seizures, and I think those have been changed to generalized and partial. Generalized are like the major, like I said, the major seizures that you see in patients: full body shaking, unresponsiveness. They may vomit. They may have drool excessively rolling from out the side of their mouth. The first thing you want to do when you see a patient having a seizure is make sure that they're safe. The patient doesn't know what's going on when they're having a seizure, so it's our job to protect them to make sure that they don't hurt themselves. So if they're on a table, you want to keep them on a table. You don't want to move them to the floor because you can cause injury to the patient, to yourself, if you try to move them. Make sure you put a pillow under their head because that's the unknocking sensation that they can be banging their head back and forth, and you don't want them to hit their head. Also, even though the book states to remove any teeth or anything within the mouth, I don't recommend it at all because a patient with a seizure has such a strong bite they can bite your finger off. So only if you can see it out externally outside of the mouth, I would say try to remove it if you can, but do not ever reach into a patient's mouth that's having a seizure because they can bite your finger off. I've seen patients that have bitten half of their tongue off after they've had a seizure. So the tonic pressure of the actual spasm itself is very, very strong, and you don't want to hurt yourself. Obviously, if you notice someone having a seizure, you want to call for help so that way they can help to not necessarily restrain, but try to keep, it is considered restraining, but you want to keep the patient safe. So you would have someone like hold their arms and keep them from hurting themselves, from banging their arms on the floor of the table. Same thing with their feet. You just want to make sure that the patient is safe and that they don't harm themselves any more than what's probably already going to happen to them. You want to observe the patient and keep track of everything that happens during the seizure. The most important is you want to keep track of how long it occurred. If it happens very fast, compared to when the patient has come in, because they may have come in for seizures, so they've been documenting every seizure that the patient has. And when they go to perform an EEG, they can at least relate that information. And EEG is just a measurement of the brain waves that they do, usually on patients who have seizures. So you want to make sure that you are documenting, at least mentally, all the things that you have seen go on or everything that you saw go on. I had a situation one time where patient was in a car accident. He had a history of traumatic brain injury and he had half of his skull removed, but he was in a car accident. They did an assessment. He was there for like 3 or 4 hours and they wanted to do a CT of his head just to make sure there was no bleeding to clear him. They had already had his discharge papers ready to go and he's sitting over in my CT bay having a seizure. They had no clue what was going on. So what the assumption that they came to was that because part of his skull was missing, when he had whiplash, he may have actually hit his brain and it sent the neurons firing all in different directions. So it didn't happen instantaneously when the accident happened. It happened after the fact, hours later. A partial seizure is like a grand mal seizure, and that may be, like I said, the situation where you may have a patient who's diabetic. It's not the same as a patient who's diabetic has low blood sugar, but the symptoms or the things that you may see are very similar. So you may see a patient and they kind of like space out. They are like looking through you. They have this deep gaze where they're just not responsive. And this could last anywhere from 1 minute to a couple minutes, and then they're just staring at you. They may start to drool as well because they've completely lost bodily function. They may also urinate or defecate on themselves as well because all of their body functions have been shut down due to the seizure. With some patients, when they have seizures, when they come out of it, they're kind of scared. So always make sure that if you notice a patient coming out of a seizure, the first thing you want to do is say, you're at the hospital, you've had a seizure, let them know what's going on, because they're very terrified. When it's nothing worse than waking up and not knowing where you are, what has happened, or anything like that. So when a patient does come out of a seizure, they're not going to just wake up and start talking to you like everything's normal. They have no clue what's going on. So just the first thing you want to do is make sure that you tell them you're in the hospital and you've had a seizure. Things like that, just try to reacclimate them, because you'll see patients, they may even get defensive. If you're standing over top of them and they've never seen your face before and they look at you, the first thing they might do is, get frazzled. Not intentionally to harm you, but they're scared. They don't know what's going on. So always just try to make sure they're comfortable and explain things to them as well. Different types of allergic reactions, and this can fall under the anaphylactic category as well. You have mild, moderate, and severe. Your standard mild allergic reaction may be a nasal congestion. You may get some swelling around the eyes. You may start itching. Itching doesn't necessarily mean that you get hives, but you can just start itching due to the medication that was administered to you. And you can start getting swelling, so a little bit of edema around the area or around the eyes, maybe on the arms or fingers, depending on it. Maybe at the IV site, you might have some swelling at that site. Moderate are the patient may experience bronchospasms, and I kind of want to relate this to hyperventilating. It's not actually hyperventilating, but it's very similar to that. The patient may be struggling to breathe, and that's what you're going to see. You'll see them, and that's the lungs actually reacting. The lungs are probably building up fluid to try to release some epinephrine and adrenaline into the patient to try to stop the actual reaction itself. You may get swelling. Even though swelling and edema are very similar, edema is swelling more with fluid. And that's your body's defense to try to protect it from whatever foreign body has been introduced. And they may get flush. So you may have a patient that might just break down in a cold sweat, and then their temperature hasn't decreased and their blood pressure hasn't decreased, but they may just get like a hot flash and then all of a sudden go cold, so they might start getting a flush appearance. A severe allergic reaction would be a substantial drop in blood pressure, additional bronchospasms. Allergic reactions can also trigger seizures, and at the very worst, respiratory and cardiac arrest. That's where the patient is suffering from anaphylactic shock and they may completely stop breathing and their heart may stop as well. When dealing with patients who come in through the emergency room or dealing with emergent situations, all facilities are required to have a pain assessment scale tool. As we all know, everybody uses the 1 through 10. For pediatrics, they use faces, like happy face, sad face, only because pediatric children may not understand the difference between numbers, so at least they can point to what face they can correlate to the most. You have to be careful with pain situations, even if we all know we have that patient that may just be trying to get back faster or trying to,
Get some food.
yeah, trying to get some medication. I didn't want to say that, but yes, it's true. We do have patients that seek drugs and go to different facilities. But with that being said, don't ever disregard your patient's level of pain or whatever they tell you that they're going through, because some people may be really going through actual pain. And I don't want to say some people, I might say everyone that comes to you may be experiencing some sort of pain. It's often difficult to determine a person's pain level, and that's why they use a scale, because you have different situations. Like scientific proven fact, sorry guys, women can tolerate pain better than men can. So a woman's 4 may be a man's 8. So you have to correlate those assessments based on the actual individual patient themselves. You can't really use it in comparison to different situations. But like I said, you have to bear in mind, because a woman may just say, I'm at a 4, but she could be really at an 8. She may just be tolerating it well. Same thing with age. When you get to elderly patients, they start to lose some of their sensitivities. They may have nerve damage to their fingers, their feet, their knees, and their legs. So their pain level may not be as excessive as it looks, but we know as human beings, looking at someone, let's say a patient has a skin tear or they have a wound cut open, and an elderly patient may be like, oh no, it's not that bad, it's okay, but you can just tell by looking at it that it may be more severe than what they're saying. They probably have no sensation, so they probably lost a lot of sensory, superficial nerve sensations to certain body parts, so we have to take that into consideration when we're assessing pain as well. And also culture. Culture plays a huge part in the pain scale, management of pain scale. It's been known that some people believe in prayer rather than medication, or some people believe in prayer rather than resorting to going back to a pain assessment scale. They may, it may be mind over matter. They may just keep telling themselves, like, there are holistic approaches, things that we can do to help decrease pain. You can do breathing techniques. You can, actually another scientific fact, it's been proven that swearing helps to reduce pain levels. I don't know, I'll see if I can find that video for you guys, but there's like a group of people that are doing the spa hot tub thing. Have you seen that? Where it's like too hot, and then they get out and then they go into the cold water. And of course, obviously, cold water puts your body in a shock, and this is like ice cold water. And they were attached to like these electrodes based on pain receptors and things like that. And it was actually proven that the people who were swearing experienced less pain than those. So there are different ways that people are going to deal with pain. I know Randy's like, I need to find that article.
Randy has some words right now.
Yeah, I've been keeping my door closed all week, so I'm like, oh my, yes. And that's another thing too, like I've been doing, even with my situation, I've been doing breathing techniques, because with a pinched nerve, what are they gonna do? What can you do? So you have to take it upon yourself and do methods. You have to find things to create it yourself. Am I at a 10? Sure, I'm at a 10, but it's all in how I perceive it and how I take it, because I can be walking around and feeling like I'm at a 4. Another patient situation you should be aware of are agitated and confused patients. They may be frightened, and they may be experiencing some sort of psychosis. They may have a known history of being agitated and or confused. Has anyone ever dealt with a patient who has dementia and you've experienced sundowners? Yeah. So sundowners syndrome is basically what it sounds like. With a patient who has dementia and they have sundowners, or they may experience sundowners, this is when they become the most agitated. They can be very harmful to members of the society, people that are working with them, things, that situation. So in my line of work, I may get patients who come in and they are just very agitated and upset family's like, I've never seen them like this before. And of course I have to do my job, but I'm very hesitant to want to try to do a CAT scan on them because they could end up fighting me, they can hurt themselves worse, they can try to hurt staff. So I asked the doctors, I'm like, what are we dealing with here? What's the situation? Obviously, we want to make sure we rule out a bleed or any other serious trauma, especially if the patient has fallen and they're starting to act in this way. You want to make sure that you can make the patient as comfortable as possible, but Sundowners is very strong, very, very strong. These patients can hurt you, and they don't know what they're doing. It's just like some extrinsic force where they have all this power, and you can't hold them down, you can't restrain them. There's nothing you can do. Sometimes you just have to let them ride the wave and make their assessments in the morning. So it's always important to know if your patient is agitated and confused, get a history, if you can, possibly a mental history, some sort of, find out what's going on, if they've ever had this before, if they have had this before, when did this happen? Usually you can kind of sort of create a timeline. And also with agitated patients, if you feel ever that you're in danger, you don't have the right to not do your job, but you have the right to hold off for a few moments or something until you make sure that the situation is safe. Because the last thing that you want to do is be in a situation where it could hurt that patient or where you can get hurt yourself. So always, that's why I say it's important to make sure you gain a history and find out what's really going on with the patient, the best of your knowledge. Know your institution's policy for dealing with agitated and confused patients. Because this can be the point where if you feel that it does jeopardize your safety, you may have to call security. And when you call security, it's not for fear that you feel the patient is actually attacking you, but it's to prevent any type of possibility of creating harm to yourself and to the patient. Some patients have to go on 4-point restraints until they're calmed down, and that needs to be ordered by a physician, but that's not something that we need to take on the role of as ourselves to try to restrain a patient. You have to be aware of an intoxicated patient or a patient under the influence. More times than not, they're reluctant to cooperate. Keep it simple, direct, and non-judgmental, and don't ever do it alone. I'm speaking from experience and obviously from the book too. Usually I have my spider senses, and when the hairs on my arms go up, that's when I'm like, we're done. I stop doing what I'm doing because I usually have that innate feeling. And this is something that you guys will build up to, especially when you're dealing with certain types of patients. You will build up that system, that gut feeling where you're like, I just don't think this is safe right now. It's not a good idea. I need to let this patient go, and we're going to go talk to someone. So always be aware of what state your patient is in, what the situation is, and part of your assessment. And we are done with lecture, so we're going to move on